Please
So,
start. 3, 2, 1. Please start. So we are live.
hello, very good evening, and it's a great pleasure to welcome you again for this exciting session. This is again bringing you deep dive in GI cancer, clinical updates from ASCO and ESMO 2026. It's a pleasure always to welcome the program convener, Dr. Vamshi Krishna, Director and Head, Medical Oncology and Hematology from the prestigious Institute of Oncology, AIG Hospital, Hyderabad. So once again, very good evening and warm welcome to everyone. Dr. Vamshi sir, the stage is set for you. You need to set a context, and I think over to you for your first discussion. Dr. Vamshi sir, can you
Thank
hear
you.
us?
Yeah, thank you, Tarun. Thank you so much for inviting us. So, welcome everybody. This is the third edition of having these updates on GI cancers that we host every year. Typically, we will try to cover some abstracts which were important and practice changing, specifically from ASCO, ESMO, and any other conference that has recently happened. The purpose of this discussion today is not just to have a simple case or a single case, but to try and see how these would influence our practice in India. So we have three panelists in each session, and in between, we will have a debate on an interesting topic. So the first topic of discussion will be with Dr. Nihanti, Dr. Soumya Panda from Bhubaneswar, and Dr. Swaratika from Bangalore. And what we will do is we'll try to cover a few abstracts in depth. We will not discuss a lot of abstracts, but a few which were really important and probably are going to change our practice. So with those few words, I think we can start. We do have some audience already. So without wasting much time, let us start the session. So Tarun, if you can put the slides for the first session. So the first session was supposed to be moderated by Dr. Amish Vora. Unfortunately, he has some health issues, so he would not be able to join us for the first session. And as per force, I'll have to do this session as well. So Dr. Nihanti from Kolkata. Dr. Nihanti, you're there. Would you, if you don't mind switching on the camera as well? Thank you.
Good evening, sir. Thank you, sir. Thank you for the
Good
invite.
evening. Dr. Soumya is there and Dr. Swaratika is there. So Dr. Swaratika seems sad that Dr. Amish is not there. She's holding her head in her hands. So Dr. Soumya,
Hello, sir.
thank you, sir. So good evening, all of you. And what we thought is the first session would be on the gastroesophageal tumors. Now, gastroesophageal tumors this year, we had a couple of good abstracts, which I will be focusing on, and we'll try to see how these abstracts and how this will change our practice. So next slide, please. So the first part of today's discussion will be on the perioperative GE junction cancers. So gastroesophageal and gastric adenocarcinomas mostly, and that will be the perioperative treatment. Next slide. So the standard of this paper is because of this abstract, the neoadjuvant adjuvant serplulimab versus placebo combined with chemo in PDL1 positive gastric cancer. This is a randomized double-blind multicentric study. Next slide. And this was presented in the ASCO as well as in the it came as a publication as well. So Dr. Swaratika, this is the pan-ESMO guidelines. Here, perioperative is recommended who are candidates. This is what we have done in the this is the pan-ESMO guidelines, and they say that perioperative chemotherapy is an option for patients who are there in stage 2 and 3. So in your practice, where do you place perioperative chemotherapy and immunotherapy? Is it a standard of care for everybody?
So it's a standard of care beyond T2 or any node positive disease in my setting.
Okay.
There are certain issues, as in blocks to practicing in private practice. We don't get staging labs done for everybody.
Okay.
So it is, and we also don't get a EUS based staging done either.
Okay.
The T1, T2 differentiation is not very apparent, especially in T2, T3, it's also not very apparent. So we by default do tend to offer neoadjuvant systemic therapy to all patients.
To all patients. Okay. This is interesting because in the pan-ESMO guideline, pan-Asian guidelines, still adjuvant or neoadjuvant are recommended. This was, of course, done when there was no, the Matterhorn had not come in place. So in a lot of Asian countries, still adjuvant is considered. So Dr. Nihanti, your take on the neoadjuvant and the adjuvant, that is perioperative versus adjuvant, you feel that we have enough evidence to push all patients for a perioperative immuno plus chemo?
Sir, if you look into the data, I think I would totally agree that at least currently anything beyond T2 and Node Plus should go for a perioperative chemo along with immunotherapy, sir.
Okay.
Adjuvant, if you're looking into the data, it's mostly either from Japan, where the surgery has been done quite adequate, sir. A proper D2 gastrectomy has been done. So
Okay.
you see, if you're going to extrapolate that into Indian context, I'm not that confident. So I
Okay.
would definitely advise all my patients to undergo perioperative chemoimmunotherapy, sir.
Okay, I think some of the surgeons who are around, if surgeons hear you, they will not be very pleased with what you are saying. But point taken. This is a discussion that we always have and a debate we have. The Americans and Europeans said mostly are preferring perioperative, whereas the Asians still stick to surgical upfront. Dr. Soumya, your take on
So
this?
can
Yes, go ahead.
Yeah,
Kritika.
after
So, because we had a rarely recently, like a year back, we had a rare case of a very, very early cancer. So that's when I reviewed it. I think those with less than 2 centimeters, well differentiated, even T2 disease can be offered. There's no strong evidence for neoadjuvant, but the rule of the thumb would be neoadjuvant.
Rule of the thumb would be neoadjuvant. Okay. There is no clear trial phase 3 which has really shown a triplet to do much better than a doublet adjuvant. But yes, point taken. At least the Matterhorn did show us that it benefited. So next slide.
Sir, I just have one comment to make.
Please.
Yeah, that is because mostly in we are not practicing a screening endoscopy like say Japan or so. Most of the lesions may be early T1 and T2 in Japan, and that's why the Asian guidelines differ a bit compared to the US and the Europe.
Correct. That's also an important point that they are much more aggressive in screening and they're able to catch tumors early. So this was the Matterhorn, which really has kind of changed our practice. It is basically a neoadjuvant of durvalumab with FLOT. It looked at a placebo with FLOT. So essentially it was two perioperative protocols, one with durvalumab, one without durvalumab. It included an adjuvant durvalumab phase, a FLOT phase of around 4 cycles, and then continued durvalumab for a total of 1 year. Primary endpoint was EFS and secondary endpoint was overall survival. There was this was limited to stage 2 and stage 4A. Remember, this did not actually include or mandate a diagnostic lab, and the PDL1 was stratified. So they had PDL1 negative, which was only around 10-15%. Mostly it was PDL1 positive. Next slide. And in this paper, the numbers, what we look at, when you see the stratified hazard ratio, it was around 0.71. So it's positive, well within the limits, but 0.71. Next slide. So this was the perioperative serplulimab. And in this serplulimab, which came also in the Lancet paper, this was only for PDL1 positive gastric cancer with a CPS of 5 and above. Next slide. And when they did the analysis, this was serplulimab with S1OX. So remember, we are talking of triplet and doublet. A triplet is 3 drugs. This is only 2 drugs. And the placebo group included S1OX, surgery after 3 cycles, and then only serplulimab in the adjuvant phase. Whereas in the placebo group, they had only S1OX for a total of 5 cycles. So we had a total of 8 cycles of S1OX, 3 before, 5 later. And the investigator assessed PFS, EFS was the endpoint, OS was a secondary endpoint. Stratification factors included PDL1 less than 5 to 50 and more than 50, and they looked at only PDL1 positive disease. So, Swartika, quick thoughts on the design. We have talked about triplet being probably better than a doublet. So, Matterhorn included a triplet. Here you have only a doublet. So, your thoughts on the design?
So, the design seems to be mirroring almost what the Matterhorn trial did in terms of inclusion criteria, except for the PDL1 testing. Surprisingly, Chinese people, I mean, most of the Chinese drugs did use TAP score, but this trial stuck to CPS as opposed to a TAP score. And their primary outcome was actually designed for CPS more than 10. Even though they included everyone of CPS more than 5, the primary outcome was designed for more than CPS more than 10. In my experience, it sort of potentially excludes bad gastric cancers because you don't find Linitis plastica poorly differentiated signet ring to have high PDL1 expression. That's one negative point. Second point is that many of our that they have capped the age at 70, which I understand might be, a trial based criteria in their setting. But we're more worried about FLOT and triplet regimen in elderly. I can't imagine being worried about FLOT in a 55 or a 60-year-old because they do tend to tolerate it very well. So that's a minus point for me because it would have been nice to see if I could mirror that in an elderly population and how the elderly population tolerated it. Third thing, in terms of design, I'm okay with it. I don't have any. I like it that they've taken an OS endpoint as opposed to a PFS endpoint. It's always
They have
nice
taken
to.
EFS. Sorry to.
Sorry, sir.
They have taken EFS.
Yeah.
They have not taken
No,
a-
sorry. My thing was, they've taken an
Yes.
EFS. I got confused with the trastuzumab trial. Sorry.
Yeah.
So they have taken an
Yeah.
EFS, but they did take it for CPS more than 10 as opposed to more than 5. The only negative point for me in terms of gastric cancers and use of oral drugs is that, especially in GA junction and those with advanced disease, sometimes they do tend to vomit, they do tend to come back, they sometimes require FJ in between. So the reliability of S1 is it's a little doubtful because even although before FLOT came, we were giving EOX and ECX and ECF and all of that. So it's essentially similar to that because you're having a 5FU and a oxaliplatin backbone alone. But yeah, I would still prefer FLOT over.
You still
SOX.
prefer FLOT. Okay. Very good. Dr. Nihanti, your thoughts on the trial design, on how the trial was done and the inclusion-exclusion criteria?
Sir, actually, Dr. Swaratika has explained in detail, but I think what points I would like to add on is first is the chemotherapy backbone, sir.
Yeah.
Because FLOT, we have a OS data where currently SOX, I'm not sure about it. Again, if you're considering the population, I think that's one of the important criteria. Was mainly Asian study. Only Asians, Chinese were included. FLOT had everyone. So it was more like numbers were quite less. Again, looking into the biology of the disease, they have taken very good biology patients in this. I think this is the first trial which actually included a predictive biomarker, which even Matterhorn didn't consider actually irrespective of PDL1 status. So I think they've very smartly designed the trial. That's what I would conclude to it. We have a lot of data on SOX for adjuvant. Even post gastrectomies, I think Japanese and Chinese data they're quite convincing that you can still go ahead. And I think even Indian patients have tolerated well. But any day with FLOT, triplet is the drug of choice. Huh? Again, one thing, age is one important factor. Maybe a patient whose PS is quite bad, or maybe a PS of 3, I think in those scenarios, I would consider a doublet. So, can this study fit in those patients would be the question which I would look for.
Fantastic. Very good points raised by both of you. Soumya, your take on this?
Yeah, this is more likely means a real world has got more real world implications. So if we look at the design of the trial, so the adjuvant arms to me were looking very imbalanced because in the one arm there is no immunotherapy, the other arm has got immunotherapy, and there is chemotherapy in the extra 5 cycles. Here there is no 5 cycles. So to me it looks kind of imbalanced, but real world implications does carry a lot for Indian context. And otherwise they had a lot of T4 and T3, so up to 50% were T3 T4, so that was good. And because lot many advanced stage was there, and PS also PS1 was 50%, unlike the FLOT trial. So real world implications, yes. Design of the trials to adjuvant part looks to me a bit of imbalanced.
So very important point which you have raised. Two things. One is real life. Now, in real life, how many of our patients are there with a CPS more than 5? I think that's the biggest problem for me. Now, we have tested now stomach, and I think percentage wise, how much would have more than 5 in your practice?
I agree with that part.
Huh?
So we have very few patients, and they've taken another of more than 50 as well. So that's a bit worrying that the number of patients are really less in our context when we look at the CPS of more than 5.
So would it be around 40%, 50%? What's your experience?
So we had evaluated. I think it is still less than that. So
It's less
probably,
than that.
yeah.
So, that is the biggest problem for me. This trial actually excludes a big chunk of patients because even though it is easier to give, absolutely easier to give, but more than 5 set of sets, some stretch for us. So, Swartika, you had spoken about certain issues. Again, this is a point which I want to bring you back on. How many will actually have more than 5 CPS? Number one. Number two, adjuvant, you give serplulimab and you give S1OX and you find that the response is, you still have node positive disease after giving S1OX. How comfortable are you omitting S1OX completely after that and giving only serplulimab?
I think the idea of comfort comes from experience, nothing else.
So you would give for a few
So
patients like this and
I
feel happier. Okay.
Yeah, it's only no, as in you learn from experience in terms of comfort. Because see, when in 2019 when FLOT came, we were all a little skeptical about giving it, and then now we're so used to it, we don't even think twice about giving it. We've added Durva to it. It's not a bad combination. So I'm not really scared to give FLOT anymore, but I am scared to omit it. Another advantage of FLOT is that you get to surgery within 2 months. I think that's pretty remarkable. And the PATSIA rates are also fairly similar. I don't think it's such a bad thing.
No, I'm not
And
about plot. I am talking specifically here when you have given serplulimab S1OX and you don't get a PATSIA. Because if you get PATSIA, it's fine. You get a
yeah,
response with nodal disease still there. In that
correct.
situation,
So,
how
sir,
comfortable are we omitting chemotherapy in the adjuvant setting? That's what I'm trying to
yeah,
ask.
I see. It's not I mean, we do what we have set out to do. If you've chosen a course, you need to complete
You
it.
need to follow it.
Even FLOT, yeah, even if you've given neoadjuvant FLOT and you have like a YPT4N2 disease, you'd still complete the FLOT, but you know that they're going to relapse at the end of 6 months or 1 year. So you
Okay.
just follow the course because you've taken that. And then with experience, you'll understand whether
Okay.
escalating or de-escalating helps.
Okay, perfect. Nihanti, for you, the same thing. This number is not so huge. You will exclude almost 50%. And how comfortable are you omitting this adjuvant setting? Adjuvant chemo, not to give at all. Somehow at medical oncologist heart, you feel a little, you wonder a little bit, are we okay to just omit any chemotherapy thereafter? How comfortable are you doing that? Because you're giving only 3 cycles of chemo. In a disease like stomach, where all of us know it's not a great disease, you could argue that giving those extra 5 won't help any which ways. But how comfortable are you omitting chemotherapy completely?
Sir, to be more precise, I don't think I'm comfortable omitting adjuvant chemo, sir. Even if you
Exactly.
look at the fallacies of FLOT, irrespective of the PATSIA, still they gave 4 cycles of adjuvant FLOT. Now here, only 3 cycles of, it's not even complete 4 cycles. It's actually 3 cycles of neoadjuvant along with an IO being given. Adjuvant, you're totally omitting the remaining 4 or 5 doses. I don't think, I'm not that comfortable, sir.
Yeah.
Let it be, even if patients achieve PATSIR, I think, okay, maybe there's a small doubt of benefit being given. I think maybe you have a good PATSIR compared to the other trials with FLOT.
20 versus 80. It's
Yeah.
2% more.
Yeah, 2%, but I'm still not comfortable omitting it, sir.
Very good. Soumya, last
Yeah,
word from you on
same
this.
here. So even 3 cycles would be a bit inadequate only with the doublet. So I don't know why they've chosen 3 instead of a 4 when the total cycle is 8. And again, after that, somebody lands up with a YPT2 N3 or something N2. So it's very difficult for a medical oncologist to omit a chemotherapy and give only a IO.
Would you have liked some ctDNA, or would you prefer doing a ctDNA in that? Because that seems to be the new thing. You do a
Right.
ctDNA, if it is negative, then would you be okay to do it? Would you like to incorporate a ctDNA right away into this, or in practice? Because this is not in the trial, but in practice, would you like to do that?
Yeah, definitely. If some data comes with some
And you won't.
background, yeah, right now, though we don't have that, but yes,
Oh,
we would like to look at that.
okay. Swatika, same thing to you. Would you be more comfortable if you get some ctDNA or something in your practice?
So a bad disease is a bad disease. If they have a high node positivity, it's a bad disease.
Okay, so you're saying that additional chemo would only add the toxicity. Anyway, it would not do so well.
I
As well omit it. Okay, fair enough.
Yeah, I don't know. I mean, if you're choosing a study design, you're choosing it. But if
Fine.
you just want
Okay.
to do what you want, you can just do
All
whatever you
right.
want.
Perfect. Next slide. So I just put this design and I have shown the numbers. Next slide, please. So remember that some other slight differences, as Dr. Soumya pointed out, the proportion of T4 was higher, the proportion of PS1 was higher. There was, again, staging laparoscopy was not mandatory. So next slide. Now, these were the numbers when you looked at the PDL1 CPS more than 10 and more than 5. The intention to treat is more than 5. Hazard ratio 0.73. Remember the Matterhorn had 0.71. Here it is 0.65 in the CPS more than 10. So higher CPS, they do better. That's something we are aware of. Next slide. And this is again the survival curves, again showing that the hazard ratio is better for the PDL1 higher group. Next slide. So this is what we have already discussed. Tolerance wise, definitely it is useful. And that's a point which Dr. Swatika made, that especially if you have older patients, this is tolerable. And for all patients, SONOX seems to be tolerable. For chemotherapy, no, it's always going to be a bit of a worry. So next slide. So let me come back. This is the PAT-CR which was there in the Matterhorn and the PAT-CR here. Next slide. Next slide, please. Next slide. So this was an interesting paper from the TMH guys who showed that if you have PAT-CR, it actually does matter. This was one doubt which I used to always face. Are we sure that PAT-CR matters in gastric? It does matter. So next slide. So is it practice changing? Swatika, tomorrow morning patient comes to you who is fit, 60-year-old, has CPS 10. Would you go the Astrum way? Would you go the Flot Durva way, Matterhorn way? Efforting
I
all
would go
fine.
if the patient is fit and affordable, I would really go the Matterhorn
Matterhorn
way.
way. Excellent.
I'd be more comfortable with it. I'm really
Good
impressed
enough.
with Flot.
Absolutely.
We've
Just
had,
want to know the
yeah.
practice. That's what I'm asking. Dr. Nihanti, your take on this.
Yeah, even I think if patient is in a very good PS, I would consider Flot and Durvalumab.
Okay, excellent.
One query to add here, sir. I think even though the Tata data showed that PAT-CR is important, we already have the data of Nivolumab, where adding a perioperative Nivolumab did have a higher PCR, but it didn't show any benefit in
Correct.
EFS.
Correct.
So how comfortable are we in extrapolating the PAT-CR here?
So, PAT-CR in general, what I'm not saying that if you have higher PAT-CR, you'll get OS. I'm saying a patient who gets a PAT-CR does well. That was the point I was making. It's like if we say in breast, a patient who gets a PAT-CR with any treatment will have a longer survival compared to those who don't get a PAT-CR. So that was the point I was making. We weren't even sure that, no, I'm not saying that increasing PAT-CR increases OS. That's not what I'm saying. I was making a different point.
These two trials here of Matterhorn
Understood.
and
I
yeah,
agree. Go
because
ahead, please.
there's a benefit of almost like 2 to 3% of PAT-CR with addition of Serplulimab in spite of just doublet chemo being given.
Correct.
When with Matterhorn, still the PAT-CR is lesser. So how can we
18 versus 20, I don't want to split hairs. To be very honest, it's not such a big number. So I don't know.
And also, Matterhorn is PDL1 irrespective, and they included
Correct.
all patients. You're
Correct.
expecting a higher PAT-CR if you're choosing your patients better.
Correct.
even if
So
patients who didn't have PAT-CR where did fare better, no sir, in that the event-free survivals were quite significant.
those who had PATS-CR, you're right. I agree, but 2% only, so I don't know whether it really matters. Soumya, we'll just finish quickly because we have another two patients' papers to go through in the next 20 minutes. Soumya, your thoughts? Patient who is fit, affordable, Matterhorn versus Astrum?
Matterhorn, sir.
Matterhorn. Very good. I'll ask you the third thing because this is what Dr. Viraj has messaged, that if you have cost constraints and you have a cost constraints for Durva and patient has a positive CPS, would you like to use serplulimab with Flot?
Yeah, in that case, that is the setting where serplulimab plus Flot I would consider, especially somebody with post-op, is not likely to get a good bit of chemotherapy and probably fit for immunotherapy, and that is the area.
Okay. Dr. Sardika, third option, patient not able to afford Durva, would you be happy to combine
Cost
flot,
constraints, I would actually prefer serplulimab with SOX only.
not
The
give
thing
flot?
of putting a PICC overnight admission is actually more expensive than the entire
Right. Okay,
chemo of
fine.
SOX.
Okay, will you like giving flot with Serplulimab? Let's put it that way. There is
Yeah,
no.
why not?
Why not? Okay, excellent. Dr. Nihanti, same question to you. Flot with Serplulimab, are you comfortable adding those two? No data, but will you be comfortable adding them? You get the
Yeah,
best of
yeah,
both
but
worlds.
yes, I think an added IO has shown some benefits, so I think I'll be comfortable adding.
You'll be comfortable adding. Excellent. So I think this trial is useful. I'm sure we're going to use it somewhere or the other. I'm still not 100% sure whether a patient who is eligible and able to take the Matterhorn should convert into Astrum. I wouldn't at this point, like all my panelists. However, in patients who are not fit for a flot, a slightly elderly patient, a PS1 to 2, where you are a little not sure and you have a positive CPS, definitely I would be happy to go ahead with a Astrum like approach. A final question, Dr. Sartika, patient with CPS less than 5, what would you do? If patient cannot get flot, would you be comfortable the other way around? Would you be happy giving S1 ox plus durvalumab?
No, I wouldn't. I
No?
would prefer giving flat.
You're okay with giving flot with serplulimab but not S1 ox with durvalumab. Okay, interesting. Okay, that's
Yeah,
fine.
I believe in flat. It's a good regimen.
So 68-year-old who cannot take flot but can take S1
That's
ox.
a different question. If the
What is the
patient is
different
fit
question
for
I'm
flat,
asking?
they'll get flat. If the
Those who
patient is
cannot
not
take,
fit for flat,
would you give S1 ox with durvalumab?
yeah, I would.
Okay, perfect. It's something we are doing in practice, so that's what I just wanted to ask.
I would.
Next slide. So this was about the part. Let's go to HER2 positive metastatic G junction and let's cover first line and a small bit of second line. Next slide. The first line was the standard of care. Okay. Viraj has said that there is no benefit of IO in PDL1 less than 1, which is a systemic meta-analysis from Matterhorn and KN 565. I don't want to go into the whole PDL1 controversy. Matterhorn, remember, initially came and they said it should be confined to more than one. And then the FDA said, no, it can be given irrespective of PDL1. Point taken, Dr. Viraj. I think if it is CPS less than 1, we'll be hesitant, but you're not wrong as per present guidelines to give it or as per present approvals to give it. But point well taken. Right. Present standard of care in HER2 positive. Everyone agrees that it is Pembro, Trastuzumab, and chemo. The hazard ratios are important here. Remember, the hazard ratio with for the OS with Pembro is around 0.8, right? And the median OS with patients with PDL1 more than 1, 20 versus 15.7 with a hazard ratio of 0.79. Okay, so your hazard ratio changes by 0.01. From 0.79, it has become 0.80. The, the actual number changes by zero point 0.1 month and your p-value becomes better. But the pre-specified boundary was lower, therefore it doesn't work in PDL1 less 0, whereas it works in PDL1 more than 1. Soumya, is that the reading of this study? Same hazard ratio, just because of statistics, we say it doesn't work in the PDL1 negative, but will work in PDL1 positive. How comfortable are you with that statement?
Not comfortable because it is kind of a very close call. So somebody with a hazard ratio of 0.79 and 0.80, that is a bit of
Exactly. I
but
know
then
it is.
we stick to the PDL1 more than one.
You will stick to PDL1 more than one. My question is the PDL1 more than one really benefiting as well with a hazard ratio of 0.79? It is just about at the boundary, but for whatever reason, this has become the present standard of care. Next slide. Next slide, please. Remember, the PFS also benefited only hardly 1 to 2 months. Next slide. So this was a paper which came out in this ASCO. This was the zanitamab tisleli with or without in HER2 positive. Next slide. Again, an interesting trial where they actually did arms where they had zanitamab tisleli plus chemo. One arm had zanitamab plus chemo and one arm had only trastuzumab and chemo. So, Swartika, was this a fair comparator? Your comparator arm does not have immuno, whereas your other arms has a bispecific HER2 versus a normal HER2, and it has added immuno to it. So, Swartika, your thought on this design?
I think the more complicated, I think it's easier to confuse people when you complicate the design. So it never
Okay.
looks good when you have more than two arms, and it's never a good idea to do
Okay.
things like this.
If you want to
So I
analyze
think
this,
that's the negative aspect of the trial.
okay. So are you comfortable with Trastuzumab chemo alone as a comparator? It's fine because at that
Yeah,
time Pembro was still not a.
yeah.
So you're okay with that study. Okay, very good.
Yes.
Okay. Snehanti, your thoughts on this? Again, the same thing. Trastuzumab chemo alone, and on the other side, you have Zani, which is a stronger anti-HER2, which we believe, plus Tislely versus chemo or without Tislely. So your take on this trial design?
So definitely, so it's quite intricate, but sir, it gives a very clear-cut identification because we have the data of Toga trial, which they tried comparing with zanidatamab, and then they've added one more arm where they compared Zani with Tislely. So I think it's
You are
quite,
happy with the study?
yeah, because it's like you're getting in the basket itself, you're able to identify whether to give zanidatamab alone or with an IO being added. Because
Okay.
by the Pembro was not there, so that's one exclusion. Rest,
Fair enough.
I'm
Pretty okay. Here,
yeah.
the data for the hazard ratio is much better. It's 0.63, which is nicer, what we like to see, and a difference of close to 4 months, which is again quite good. Next slide. When you look at the overall survey, now we don't have all the results yet out of it. One interesting thing is the difference starts after 6 months, which is when your chemo stops. So both the arms, once the chemo has stopped and your targeted is starting, that's when you start seeing a difference. So probably this is where the stronger anti-HER2 effect starts kicking in, and that is along with the Tislely as well. Next slide. The same thing you would see when you're doing the OS, the PFS of Zani plus chemo alone. Next slide. Again, if you see, the benefit starts at 6 months. That's where your effect of the chemo wears off. This is where Zani may be having an edge over Trastu. Soumya, is that a fair way to look at this study?
Yeah, means the trial was designed at the point where the Pembro was not the standard of care, so we accept that part. The authors have acknowledged that part, and yes,
Correct.
the difference starts after 6 months. That part is also there, but the reason we are not sure, but probably that's one thing that Zani might be having a better or more potent anti-HER2. We are not sure of
Perfect.
that.
Sure. Next slide. Next slide. So this is the overall survival, again showing similar things here. Interesting, the curves cross each other at around 7-8 months. I don't know what it means, but that's what is shown. Again, if you look at the overall survival is however around 26 months. So it crosses the 2-year line, which is quite huge. 2 years survival in a HER2 positive metastatic breast stomach cancer is great. Next slide. And this is the overall survival of the Zani arm alone. And here the hazard ratio is 0.8, crossing the unity. Absolute number is again the same, 24.4. So in effect, your result by adding Tislely increases your statistical outcome, but actual number is just reduced by 1.5 months. So important question. Swartika, you think that Tislely is adding something here, or Tislely is really not doing much here?
So I think it would have been nice if they had substratified this based on PDL1 also. Then there'd be a little more clarity on the curves because we in gastric cancers we're still trying to identify, especially in HER2 positive disease, which is the arm which actually benefits from any immunotherapy, whether it is Tislely or Pembro. But we know that any HER2 positive disease, there is a role of immunotherapy because we know it's being taken early on, even in lung, even in other cancers. And I think immuno is going to come in breast also, in HER2 positive breast also. So there is a biological rationale of adding immunotherapy to HER2 positive disease. The problem is that we just don't know how to identify the subset of patients. So it's not fair to say that there's no role of Tislely or that it contributes very little. Because gastric cancers are bad cancers, and even a PFS benefit of 2 months, 3 months, and you're adding a relatively non-toxic drug is not a bad option at all.
Very good. So Nihanti, you agree with this? A triplet or a quadruplet is better than a triplet. Zani plus chemo plus Tislely is probably better than Zani plus chemo.
Yes, at least if you're looking at the graphs, definitely at this interim analysis where there's a OS benefit seen with Zani, with Tislely and chemo, I think, yes,
That's
maybe
what
a
you would prefer.
yes, so with the PD-1 blockade has done.
Very
Because if you're comparing the comparator arm where Zani with chemo alone or that hasn't shown any benefit yet. So
Okay.
if you're going to
Okay. So
extrapolate, yes, sir.
I agree. The explanation we really don't. Next slide. So, Dr. Viraj, in the meantime, can I ask you to type your opinion on this? Does Tislely add or is it not needed here? Yes.
Just a
Please
point,
go.
sir. So I means right now we don't have the data to tell that Tiscali addition is doing a better job than without Tiscali. So I think that part is very clear. So until and unless, and fortunately they have made a pre-specified OS 3 analysis that they will make. PFS is only one. So PFS they have declared. The OS there will be three more, two more will be coming up. So
Okay.
until and unless we have that, I think if we
So
have
you
a
will
Herpro
wait.
driver, we want to put the money, probably we'll be putting it on the
Yes.
journey.
So you will wait. Very good. Next
So
slide.
exactly the point I wanted to make. Yeah.
Yeah. That we better to wait. We may not tell, this is not enough to tell us whether the Tislely is really adding or not. But I think what Swartika made a point that at least in PDL1 positive, you tend to add some immuno. If you have a CPS 10, 20, you would be happy to add an immuno. CPS 0, yeah, we don't know. Next slide. Next slide, please. Can we have the next slide, please?
Yeah, 1 minute. I think Dow's laptop got this thing.
Oh,
1 minute.
okay.
Share here.
Okay.
By the time we have Dr. Viraj here with you, so
Yes.
you can.
Next slide. So we have discussed most of the thoughts. Please go ahead. So next slide. Next slide. Next slide. So this is interesting because we would know whether this is going to be approved or not. There's a priority review. August 25th is the date we will know whether this is going to be approved or not. And I think will be interesting to see whether FDA approves only Zani or it approves Zani plus Tislely. It will be an interesting result on that day. Next slide. So coming to a very more important question, we don't have Zani. We are unlikely to get Zani. What about TDXT? Next slide. So there are two studies going on. There is first line TDXD gastric O5 and I think O3. Now, first line, if TDXD comes positive, Zani comes positive. Soumya, your take. Would you give TDXD, Zani or Trastu Pembro? And TDXD and Zani with or without immuno?
Yeah, if ADHD data is close to something like more than 24 months that Zani, then probably I'll go ahead with the TDHD data. Means TDHD as a first line.
Okay. Swartika, your gut feel. Again, we don't have the full data of TDXD, but your gut feel, TDXD versus Zani, which will come in place? Which is better?
TDXD.
TDXD. Okay, fine. Nihanti?
So if you look into the mechanism, Zani is a bispecific,
Correct.
so definitely sir, TDXD, I think we are all experienced with breast, so gut feeling says TDXD, but looking
Okay.
at the mechanism, I think Zani may
Okay.
do well.
Soumya, Zani versus TDXD, your takers. This is sponsored by both of them, so you can be free.
Yeah. So the toxicity concerns are different. Zani is really toxic. Even with loperamide of 7 days, 4 milligram BD, it had 25% grade 3 diarrhea. So I think that grade 3 diarrhea of 25% is really a tough one. And TDXD, so we don't have the sequencing correctly as of now. So my guess will be it will be TDXD is more comfortable and
Okay.
that is the one I'll bet on.
Okay. Anyone has given as Zani? Any of you or? No. Okay. So we have been lucky to use Zani in a few patients as part of trial, not in stomach, in BTC. And anyway, I'm a bit biased towards it because like Nihanti said, the toxicity is actually, I found a little better, but again, very few numbers. So I will not go into the details. But my personal feeling is it's a bispecific. It will work better as compared to TDXD. That's a personal bias. I agree that everyone is liable and we'll see the results. Next slide. Next slide. So this two trials which will come in soon. Next trial, next slide, please. One is the next slide. Yeah, next. Okay. This is the dose escalation of the Destiny Gastric 3. And they did release some results. Now, this is a complicated study. They have a part 2, part 1, arm D, part 4. So, it's multiple arms. So again, like Swatika said, I think more than 2 arms and we tend to get confused. So look at the number of arms here. Next slide. The safety wise, it is good. That's what has come out. This is the Destiny Gastric 5. And interestingly, again, look at that. They have an arm M1, M2, E1, E2, and it's going to be complicated. But they have removed platinums. That's a very interesting. They have one part of the study where they're testing TDXD plus capecitabine plus pembrolizumab, removing the oxaliplatin or any platinum completely. So very interesting. I think these will give us more things to discuss in future. We don't know the answer. Next slide. So next, what we will discuss is we have just 2 minutes left for discussing the last paper. Next slide. So this is the design of the Destiny Gastric 4 looking at TDXD versus ramucirumab and paclitaxel, straightforward two arms. Okay, Swartika, only two arms here. So nothing to confuse us. Straightforward TDXD versus ramucirumab paclitaxel. Next slide. Whether Ramu and Pacli is a good drug is a different discussion for another day. We can go there. But this was what was used. Next slide. And interestingly, in this paper, next slide, they have looked at and they found that the TDXD has done better than Ramopacli as expected. One part which they have looked at is the HER2, whether it was 3 plus or 2 plus, and they found that it works in both the groups. So this was something which somebody asked me, 2 plus, does it work or not? So that's where it is. So Viraj has said he would go with a keynote 811 followed by Destiny 004 followed by Rainbow. So that is probably the standard which is going to be there for now. Whether we follow that after the full results are out, so I think that's the discussion. So Soumya, would you go with a Zani or a TDXD first, or would you go with a Keynote 811 followed by a TDXD because you have data in TDXD in second line? What would be your
So
approach?
as of now, so it is easy. It is a bit easy.
As of now, it is easy.
Yeah,
As of now,
because I
for
would
the
give and
future.
then follow it up with the TDXD. But
Yes.
once the Zani data and the TDXD comes up, then the things will be completed. So I think as of now,
Okay.
we'll reserve
Perfect.
TDXD.
I agree with you. It is easy now. We don't know what will happen later. Next slide, please. Is the laptop still stuck? Next slide. And next few slides. So this is what I was showing, the number of patients and the PFS. Again, the TDXD is better. I think most of us will really be okay with this. Surprisingly, the PFS was only 0.67. And look at the curve. It's very, very close to each other, but that's how it is. 1 month benefit. Next slide. The OS also is better by 0.7, still significant. And again, like I said, it seems to have overperformed. The Ramu Pacli arm has actually overperformed compared to what it normally does, which could be because it's a HER2 positive. We don't know the other things. Next slide. So this is about the prior treatments. Next slide. One word on the HER2 negative. 1 minute for this. Next slide. The attraction 6, looking at Nivo EP. We don't know the PDL1 here, but the Nivo EP combined with chemotherapy as a first line, and the trial was negative. Next slide. So Soumya, Nivo EP negative. You are next slide alone. Next slide, please. Nivo
Not
EP is
attracted.
dead, not attracted. So attraction 6 has not attracted. Uh, Soumya. Swartika, attraction 6 attracted you, no attraction.
No, I don't think it's
Or
attractive
nothing
anymore.
attractive about this. Okay. Nihanti?
Sir, I think it's still the abstract. Even though it's a negative trial, I think I would want to look into what has caused it negative.
Yeah. Unfortunately, only abstract. Final paper has not come, but Nivo EP plus chemo, I know. The thought makes me a little stressed about the amount of
Toxic also, sir. Like Nivo EP
Will be-
itself is toxic, so I'm not sure how chemo is
Yes.
going to.
Yes. And incidentally, if Dr. M.B. Chandrakant is listening or someone of his students is listening, please give him my thanks. When I looked at the Attraction 6, I found his cartoon created by him, and I have been shamelessly enough to use it because it's available on Google. So thank you, Chandrakant, for your good work in making these slides. So that is my last slide. Next slide, please. So that is my last slide. And thank you to all my panelists for a wonderful discussion. It was really nice to have a discussion on the G junction, whatever limited things we got. So thank you, everyone. Can stop, close the slide.
Thank you.
Thank you.
So thank you, Dr. Vamshi sir, for setting a context and a brilliant presentation and a discussion as always. And thanks to the esteemed panelists for a wonderful discussion. Now we are moving forward, and this is very interesting, a debate. And that to the topic is the ctDNA for adjuvant therapy in colorectal cancer is both prognostic and predictive. Now to do the honors for, we have Dr. Karan Sood from Mumbai. Dr. Karan sir, good evening to you. Can you, open your window and introduce yourself for the talk? And if it is not, then again, we have Dr. Viraj Lavangya. We can see, sir. So once again, ladies and gentlemen, very good evening. So here's a debate for you, and we invite Dr. Karan Sood first for his discussion. Sir, you can make it full screen. Over to you.
I hope my slide is visible and I'm audible.
Absolutely, absolutely, absolutely.
Okay, great. So thank you so much for the opportunity, Vamshi sir. And I don't know if I would make any justice to the topic standing against Dr. Viraj, but I just quickly take everyone to a few trials that I could find, and maybe there are some trials that Dr. Viraj would probably come up with in his slide set. So, I'm talking about the role of ctDNA in the adjuvant setting. We know the S is for molecular and ctDNA. So, some conflict of interest. I am a little bit known to, Dr. Sahu and following, but I have no equity in Natera or and some personal bias on unhealthy emotional attachment to evidence, especially, working along with Dr. Anand. Sorry, Dr. Viraj. We'll still be friends, but I hope our Manchester keeps us together. So just making it clear, sometimes without the spectacles or without the glasses, you might not see the evidence as it is. But let's see if we can put on the glasses and make the evidence a little more clear. So it's kind of a burnout moment. He himself has a paper which states the utilization of ctDNA, and if you see, he's using it almost 70% in the stage 2 and in the post-op setting, and almost 70% in the surveillance setting. So I think the debate should end here, that he's not in opposition to ctDNA, but he is already using it in his practice, and this paper from Frontiers actually tells it. So I think this is more or less giving a snapshot of what the gibberish is about the adjuvant stage 2, stage 3, high risk, low risk. And we all know that, in the relapse, so about 30% patient relapse post the surgery, and some amount of it is cured by the adjuvant chemotherapy. And if you see the low risk, the absolute DFS gain is about 8%, and the high risk, it's about 20%. Again, this is putting into context of what we do in what stage for what reasons and what idea recommendations are. I mean, it is difficult to take, but when you can substitute all this slide with a simple ctDNA negative positive and giving adjuvant chemotherapy or not giving adjuvant chemotherapy, it is much easier. And especially the Gen Z looking at would definitely say this is not worth remembering. So let's also talk about this sensitivity of CEA in the early stage and advanced stage. So you see, as the stage increases, the sensitivity increases. So itself not CEA is itself not a very good marker. And when we see the correlation, you can see that the coefficient between the ctDNA and CEA was to the tune of 75%, and it was lower in patients without liver and lymph nodes, but it was higher in patients with liver metastasis. Also, let's see that how we surveil patients. We surveil patients with CT and CEA, and you see the overall OS rates. When we do an intensive imaging with CEA, it's almost similar. It's about the tune of 80%. And when we talk about RFS, it's also similar. So, there's no point doing 3 monthly, 6 monthly, and, not finding out microscopic disease, not getting that lead time to know the patient is about to get relapsed. So just talking about how we've, over a period of time, we've seen multiple trials, multiple retrospective series telling us that, for patients who are post-operative ctDNA negative in stage 2, stage 3, they do much better. This intercept trial, if you see the left side, the ctDNA detected post-op in the stage 2, the 12-month DF was almost 40%. The stage 3, it is 50.4%, and stage 4, it is 6.9%. So you see a lot of false negative, but this study showed that it is only 1.3%, and this study specifically used to Signatera. Now, talking about the SWOG's 1872 trial, so they did analysis of the ctDNA, and they saw that stage patients, patients had almost 80.7% ctDNA positivity. Higher predilection for ctDNA positivity was male sex, T stage, and N2, and saw that ctDNA is having a worse DFS with an HR of 6.5 and worse OS with an HR of 6.28. And the DFS 3-year was 86% ctDNA negative, and you see the whooping 36.8% ctDNA positive cases. So the intervention in this trial was that a patient had a ctDNA positive, they gave celecoxib, and they saw that at 3-year DFS was increased to 44% versus 26% with an HR of 0.5. It was numerically better, but it was statistically not significant. Now, let's also talk about the bespoke trial where they wanted to check about the ctDNA in the adjuvant setting. This was a trial done in the United States. It was prospective but observational. They had good amount of patients, and they did the sustained ctDNA measuring, not at a single time point. Use Signatera. Almost 7% of the patients were positive in stage 2, and 21% were in stage 3. And you can see that ctDNA positive patients had a worse DFS in both stage 2, stage 3. In the MRD positive group, patients who were giving adjuvant chemotherapy, their median DFS increased from 6.7 to 18.7. We see that there was no much benefit of adding adjuvant chemotherapy in the MRD negative space within HR of 1.1. So this definitely gave us, a hypothesis of doing a sustained ctDNA, and you can see the same things here. You can see in the left, the adjuvant chemotherapy, the 2 years, it was 40 versus 24, it was 17 versus 7, and MRD negative, not much difference. Now let's talk about the dynamic. It was done in stage 2. The samples were taken 4 weeks post surgery. Patients who were ctDNA positive received 5-FU and oxaliplatin, and the patients who were negative were not treated. Primary endpoint was RFS at 2 years, and it was a non-inferiority. 5 years RFS was 88% with CT guided approach, and it was 87% in the standard management. So one would say that there is no difference. But if you go and see the relevance, it is less adjuvant chemotherapy for patients who are ctDNA guided, and for patients who were with standard management, it's 28%. So you see there is almost a relative risk of 1.82, and you can save these patients by doing a ctDNA. So you're not getting excess toxicity of a neuropathy, neutropenia, and mucositis to these cases. So now this is the Altair study. Now CRC who had undergone resection, and they also included the oligometastatic sites. Here 243 patients were randomized to FTD and TPI for 6 months, and the patient group which received this combination had the TFS of 9.3 months versus 5.5 months. And if you see in the table above, the stage 4 population which had a higher MTM per ml had a better median DFS compared to the placebo. So this again tells us that patients who are positive for ctDNA, some kind of intervention could be helpful. As earlier we saw that with celecoxib, the patients had a better DFS. Here we are seeing that this combination also helped in patients, especially we were stage 4 with better DFS. Now let's talk about the Dynamic 3 trial. Again, it's a multi-center randomized phase 2 to 3 trial. They used the DNA testing 5 to 6 weeks after surgery, and they were assigned to ctDNA guided or standard of care. And the ctDNA negative received de-escalated therapy, whereas ctDNA positive received an escalated therapy. There were almost 1,000 patients, of which 72% patients were ctDNA negative. The ctDNA negative patient experienced significantly fewer recurrences compared to the ctDNA positive. Now, this is important. The ctDNA negative patient de-escalation reduced oxaliplatin use from 88% to 34%, and hospitalizations from 13 to 8.5%. Now, this is very important if we see in terms of hypothesis. I know it was not a positive trial, but definitely it leads us to more important signals, which I'll talk about later. Then comes the Pegasus trial, where the post-surgical liquid biopsy in especially stage 3 and high risk stage 2 was done. Now this has a very interesting design. So if you see, they used Guardant Reveal assay in the post-surgical. If liquid biopsy was positive, they had given them 3 months of Capox. If it was if negative, then 6 months of CAPE. And after one cycle of CAPE, they again saw that if any negative biopsy or positive biopsy was there, they escalated the treatment to Capox. At the end of treatment, liquid biopsy was again repeated. Capox treated patients were switched to FOLFIRI if they were positive, and de-escalated to CAPE it was negative. And CAPE treated patients received Capox if they were positive, and they went on to standard follow-up if at the end of treatment the liquid biopsy was negative. So if you see the results, the post-surgery ctDNA was detected in about 26% of the patients, and 9 out of the 100 negative were defined as a false negative. So the ctDNA positive, the HR was 4.37 for the risk of relapse, and after 3 months of Capox, 11 out of 35 liquid biopsy patients converted to the negative biopsy, but again 8 out of 11 relapsed. So we see that this escalation and de-escalation wave, we can identify some patients. We are on it. We don't know which patients exactly to give de-escalation, but definitely these signals are very, very encouraging. Now, these are a few trials, which help us understand that how we can, rather than just bombarding patients of ctDNA positive with chemotherapy or celecoxib, we need to be a little more molecular. So this trial basically used Reveal Guardant. They saw the ctDNA positive patients who were biomarker negative were randomized 1:1 to FOLFIRI or active surveillance. That was arm 1 versus arm 2. And then ones who did not have any ctDNA, they were surveilled with imaging and ctDNA every 3 months. But then who were ctDNA positive, they saw the biomarker positivity, especially the MSI, BRAF, and HER2, and they gave the patients molecular directed therapies. The results of this trial are still awaited, but definitely this trial is going to, put an end to the debate where, we are escalating or de-escalating treatment based on just chemotherapy. Now, this is also another interesting trial, that is the TRACK Part C. Here they used ctDNA in the stage 2, stage 3 CRC. It's still accruing. They want to do a ctDNA guided treatment for patients who are molecularly negative or who have molecular based mutations, and then give therapy to them and significantly reduce the adjuvant chemotherapy and toxicity associated with it. So we have a lot of things, lining up in the ctDNA domain, but definitely one can see that there is a good lead time advantage of about 7.8 months and 5.5 months in the intercept and almost 100% in the victory. So one might say that what is the availability, what is the cost, logistics, their standard assays in India, lack of training of doctors, what are the false positive negative results, is there any molecular noise associated with the mutations that we are seeing in ctDNA, is it too early, etc., etc. But what the other person might say that if buts and maybes, but I'm very sure these absolutes are definitely going to stir some minds and order more ctDNAs. So I think with this, I'll probably just say that this evidence is itself telling us that TNM is a foregone, thing. We need to move to ctDNA. We know the HR is just almost to the tune of 7 to 8 times compared to the TNM staging, and the molecular proofing is the way to go. So thank you with that, and thank you for the patient listening. Over to you, sir. And sorry if my images had you for anything. So sorry about that.
Thank you, sir. Thank you so much for your excellent discussion. And moving forward for the next, against the topic, I would like to invite Dr. Viraj Lavangya, Director Oncoscience Medical Oncologist at Shelby Hospital, Ahmedabad. Over to you, sir. It was an excellent presentation, sir. Karan Sood, sir.
Thank you.
Thank you, Dr. Vamshi. Thank you, Horizon, for having me here. And Karan, you did an excellent attempt in trying to persuade everyone about use of ctDNA-based MRD. Now, I'm sure 76 participants are there. Majority would know, like you rightly said, that I'm a big fan of this technology. Having said that, this debate was not about whether one uses it or not. It is about, dissecting the data that we have currently today. And when I heard your talk, it was mainly about encouraging, hypothesis generating, future is there, so on and so forth. So we want to talk about today. All right. And Dr. Vamshi did an unfair job in putting me on this side. I would have loved to speak about the other part. So there's no doubt that this tech is prognostic, and you spent half of your time in sharing me that if somebody has ctDNA negative, they had excellent prognosis. If it is positive, they had bad prognosis. I think so that debate is gone at least 2 years ago. The question is that, is it predictive? And I think so the debate, and for the next 8 to 10 minutes, I'm going to show that it's not that black and white. With the current technology that exists and current randomized studies that we have, you showed a lot of observational studies like Bespoke or Altair. These are not randomized studies. Act 3 has not been yet. Act 3 and TRACK both have not been released. So currently what we are left with is just 3 or 4 randomized trials, and none of them have convinced us that as of today's biomarker, which is available to us, is predictive. Okay. And what do you mean by predictive? The question is, if you are having a stage 2 low risk patient tomorrow in your clinic, T3 and 0, or no high risk factor, can you safely de-escalate if your ctDNA is negative? Right? That means you are taking a call on a report. That means, is it predictive? And you showed a dynamic study, which was one of the first randomized studies to come in this space. We all know about this. We had a 5-year data saying that yes, and you showed it in your presentation, that if you use ctDNA versus you use your brain, your survival is same. And at same time, you reduce patients going on chemotherapy by half. Very good, bravo. But you left out the most important point. You see here that patients who go on chemotherapy, if your ctDNA is positive, everybody has to go on oxaliplatin. Like majority of them has to go on oxaliplatin. And think about it. It's the oxaliplatin which we want to avoid in an adjuvant setting because of the long-term neuropathy. It's never about fluoropyrimidines, right? So the main objective of the study was to reduce neuropathy or reduce patients going on oxaliplatin. In fact, we did the other way around. You see, instead of 10% of patients would have got oxaliplatin, if a physician were to decide who gets doublet and who doesn't, versus 60% of patients, you would end up giving oxaliplatin. So clearly, the goal of reducing oxaliplatin was not achieved by dynamic. And that's the reason NCCN did not endorse this trial and put it in the guidelines, because otherwise it's a very clear-cut study. What about stage 2 high risk? You know, people always say, Viraj, T4 and 0, are you ready to de-escalate? T3 and 1, are you ready to de-escalate? Well, according to you, Bespoke study and the Japanese Circulate study, you showed that if you had ctDNA negative, giving chemo versus does not giving chemo, the survival was 89%, right? But that was observational data. What about prospective data? So in the dynamic study, about 15% of patients were T4 and 0s, okay? Now see what happens here. Just ask yourself, if you are faced with a T4 and 0 in your practice, how many of them you would not give chemo? Do you remember a case where, and if it's not MSI high? So in this, if you see around only 14 patients out of 20 get chemo if the doctor was deciding. So that means almost 30% of patients who are T4 and 0, you would not give chemo. I don't think so. This reflects the practice that we are doing right now. And if you see in ctDNA-based treatment, I agree. The number of patients going on chemotherapy is reduced. But again, out of this 14, only 2 gets oxaliplatin if the doctor was deciding, while if ctDNA was deciding, 8 out of 12 was getting oxaliplatin. So clearly, I agree that the survival is same, but the most important point of reducing oxaliplatin, you did not alter. In fact, you made worse neuropathy by doing ctDNA-based guidelines, ctDNA-based guidance. And hence, again, the T4 component of dynamic was not well received by the guideline makers. Now, you also showed dynamic. You also showed Pegasus. Pegasus was a complicated study. In here, we had high-risk stage 2 and stage 3. And you like you rightly said, if you had 2 negative ctDNA, they wanted to see, can we omit oxaliplatin? Fantastic study design, right? But you see the statistics. They needed 134 patients, only 134 patients, but they did not even recruit that many. They recruited only 100. And they were supposed to have 90% recurrence-free survival at 2 years. They missed by 2%. So statistically, this was a negative trial. You can always argue that yes, 134 hota, to ye number 90 cross ho jata, so on and so forth. But the point remains that by the book, by the statistics, reducing to capecitabine monotherapy in a ctDNA negative status, we're still not sure that we are doing no harm to these patients. Okay. In this trial, I do agree that they did show that the reduction in neuropathy was real. But if you see, they wanted to compare it with the TOSCA analysis. They wanted to benchmark that by reducing patients to only monotherapy, are we harming our patients? So the graph looks very much close to each other, but they're not close. In colon cancer, 3% DFS is a big enough amount. So you see, Pegasus, even in this analysis, was off by almost around 2.5 to 3% compared to the original TOSCA. So again, this did not convince us whether you can safely de-escalate to capecitabine monotherapy if you had ctDNA negative. What about stage 3 disease? You showed dynamic 3 study. You rightly showed that yes, in this, they did achieve one goal, that the use of oxaliplatin from 88% by the doctors reduced to 34%. Bravo, excellent. But at the same time, you also had the duty to not harm your patients, right? So did you do that? And the short answer is no, you did not do that. You had a 2.8% worse survival. And statistically, this was inferior. So it was not non-inferior, right? The margin was supposed to be minus 7.5, and you crossed it and you went to minus 8. Now you can say, ek idhar ho jata, do idhar ho jata karke, and the margin would have been set. But when the de-escalation was formally studied in a randomized fashion, either in Pegasus, Dynamic 1 and Dynamic 3, statistically, we have always missed the margin. So it really brings the question that we are there yet, but we are not there yet. That's how the scenario I would put it. So by the books, again, after Dynamic 3, NCCN holds its position that we should not de-escalate based on ctDNA-based MRD testing as of today. All right. So I do agree that ctDNA negative is excellent prognostic marker, but is it a clinical license to de-escalate today? Not sure. Yes, we are sparing the neuropathy, but at the same time, are we preserving the survival? Not sure. We need track study, and we need, there is another circulate prospective study, which will answer these questions. These are large 1,000-patient data sets. Before that, doing it in clinics may be questionable. Now, the third part, what if it is positive? You showed very nicely that if ctDNA is positive, they are doomed. I agree with you. But does it mean, do you change your treatment then? We've always been taught about when we give preoperative treatment and then the surgery happens and there is no response on the histopathology, we assume that changing chemotherapy makes sense. And many of times we have foil in our faces, right? Like in gastric cancer or the bone tumors we learned in our oncology training. So even here, did the randomized trial show that changing helps? And again, here the Dynamic 3 had a cohort where they said that if you are positive ctDNA, I would take you up to triplet chemotherapy versus a standard doublet chemotherapy. And again, no benefit. So here, doing FOLFOX, which me and you would anyways do, adding irinotecan did not improve survival at all in the bad cohort of patients who are ctDNA positive, right? They were supposed to fail, but in the randomized fashion, they did not. Of course, there are fallacies of these tests, but going broadly in a randomized fashion, this does not show us that escalation improves. The only trial which showed escalation improves was Pegasus trial, but here again, the numbers were so small, and you rightly showed that it was 24 patients. Out of 24 patients escalating to FOLFIRI, you changed the lives of 11 patients. So I'm sure 11 out of 24 is not something which would end up in the guidelines. However, I have an important, I think so we have an important way where we are moving forward. So today I believe it's not predictive, but in the dynamic study, we were showed that if you were to improve your technology, okay, so in dynamic, they used a 15 gene probe. Now, what if you used a whole exome sequencing probe? Would you have increased the sensitivity and increased the specificity? And they looked back. So Professor Genitai looked back, took all the samples and redid the whole exome sequencing on them, and clearly showed that the sensitivity and specificity increased in those numbers. And hence, you would have avoided your false negatives and false positives. Even in our country, and like you rightly said, we are using it in our clinic. We did a retrospective study of Guardant Reveal prescribed in India. So these were 70 patients, and we have median follow-up of 1.5 years now, out of which 54 were MRD negative. They were prescribed in the MRD window. Now, importantly, 14 of them were the cases which were prescribed before June 2024. And if you remember, before June 2024, Guardant used to use the old platform, which was called the Lunar One platform. And after 2024 June, they were using Infinity platform, which is far more sensitive. And what you can see is that the false negatives back then, if you were one of the prescribers in the olden days, you had a pretty high false negativity. So your sensitivity was not good. Versus in the current era, your sensitivity was improved. So what I'm trying to show you is that there is a huge scope of improvement required in the current technology of MRD that we do today. And until that happens, until the randomized study happens, the algorithm, which I very much like that one day we want to reach here, but it's not today. It's for the future. With that, I thank you for your patient listening.
Thank you, sir. But the debate, I think, continue, and I would like to have comments from Dr. Vamshi.
So, thank you both the speakers for a fantastic debate. This was really a very nice debate, and I think I should specifically thank Dr. Viraj because he, as he said, does believe in the thing, but he has really dug out the fallacies in the data. Unfortunately, there is no large randomized 3,000, 4,000 patient data which would give us the right answer. We are going to keep fighting because all the data is only on smaller numbers and will always have a little bit of here and there. I think everybody agrees at this point that ctDNA is prognostic. Whether it is predictive enough to omit chemotherapy or give chemotherapy, I think we are going to debate that for a while. Like Viraj said, probably a stronger and better testing method, maybe a more frequent testing method might give us the answer. One of the challenges is, or rather the biggest challenge is, even if you identify a circulating tumor DNA, we don't have great treatment options available. Our chemos will always make a difference of 2 to 3%. Unless you're able to identify targets, something like in adjuvant lung, we have targeted EGFR. You know you're going to target it, you're going to get a result. In colon, we unfortunately don't have that. Until we get some version of immuno or some version of another treatment that will target it better, I don't think we'll be able to translate this detection of early relapses into a significant survival. So that's my take on it. But thank you, Viraj, for doing this. Thank you, Karan, because both of you argued against your nature. And though Viraj may not remember this, long time ago, he had initially suggested this idea to me that you should make people discuss or debate things against which they disagree. He has forgotten that point, but I'll remind him today that he was the one who gave me this idea in the first place. So thank you, Viraj, and thank you, Karan. And now we'll go on to the next panel discussion, which will be again of probably 30-35 minutes. So if you can just give me a minute, I will share my screen for the next debate, which is going to be on pancreaticobiliary. So Tarun, you can invite the panelists in the meantime.
Yes, sir. So I would like to invite the panelists on board, Dr. Smita Kayal, Dr. Aju Matthew from Kochi, and Dr. Ashish Singh from Vellore. Panelists can kindly switch on your video so to have a great interactions.
So Dr. Ashish, you're there?
Hi.
Yeah, hi
I'm not.
Ashish.
Yeah,
Hi,
hi.
Dr. Smita.
Hello, Dr. Vamshi. I'm
And hi,
sorry,
Dr.
the
Ajay.
video is not working.
That's okay. It's all right. Not a problem. Dr. Aju, you're there? Yeah, hi Aju. Great. So we will talk of discussion of GI cancers, pancreaticobiliary. It was all about this molecule, daraxonrasib. There was a standing ovation. There has been plenty of press release on this. There have been plenty of patients bugging us with this drug. So next slide. We should discuss this as most of our time, and this came in the NEJM as well. This was the title of the paper. The trial is called Resolute 302. So next slide. Let's start off with an easy question for all our panelists. Yeah, repeat after me 5 times. Can anyone do this? You just have to repeat this simple drug. So this is not the easiest. Yes, Aju, please try your luck. You have practiced this. So I simply call it Daxib because it is easier for me. Next slide. It is easier to just call it a Daxib because and get it over
But,
with. I don't know when
Dr.
I'll.
Vamsi, I
Yes.
think very soon we'll have to learn like Chinese
Yes.
or because there are so many of them just following this.
Yes. Agreed with you on that
Yeah.
topic. Or you should just make short forms for them. It makes life easier for all of us. Next slide. So the next slide. So this is actually a number called RMC 6236, which, if you ask me, is easier to remember than daraxonrasib. So that's the number. So coming to metastatic CA pancreas, next slide. Normally, what are the biomarker tests that we regularly do in practice, at least till this paper came about? So Ashish, in your practice, what would be the normal test that you regularly do? I'm not talking about ideal situation where you would do for a very high-end paper, but in general, like in
Yeah.
lung, insist on it. Are there any tests that you insist on doing in pancreas?
Yeah. So I think, yeah, usually, it's not so common to have a lot of tissue in practice, especially if sometimes the biopsies are difficult, especially the head region. But if you do have them, you should not be missing an MSI, high pancreatic cancer, which in itself is very rare. We would have seen just 1 or 2 patients. Now, after the olaparib study, that again became important, but that again is not so common. Now, by most all can have RAS mutation, right? And so much so that earlier we used to actually discourage sending a large panel comprehensive genomic profiling if you already know that your PCR picked up a RAS mutation, because we thought they were mutually exclusive. But now I think that has changed. So yeah, in short, we would not want to miss an MSI. We would want to do a panel which includes the RAS-RAF and yeah, and then the BRCA. Other things like MTAP loss and all that, it's coming up, but as of now not standard because only in clinical trial.
Perfect. We'll talk of MTAP later. So right now you will be doing MSI by IHC, BRCA, and a panel which includes RAS. That's the general broad thing you would be.
Yeah. So now we have a panel which includes almost 50 gene panel, 150 gene panel. That includes almost everything what we need to know. DNA and RNA, everything. Yeah.
Dr. Smita, how would you be insistent on doing all of these? Because the numbers in pancreas are low. You don't really have these big number of mutations seen. So what is the normal practice that you're regularly doing till now?
Generally, we would not recommend any of this test for most of our patients who come. First go by all the clinical factors of the general condition, the goal of therapy, or the supportive care requirement, and then decide on the initial first-line systemic therapy. As Dr. Ashish was mentioning, the role of BRCA inhibitors and those PARP inhibitors are there as maintenance therapy for fit patients who do respond to platinum-based therapies. But in practice, we decide case to case, not routinely for every patient.
Okay. So in practice, only few cases. Dr. Aju, you showed us that doing NGS routinely gives you 8% actionability in Indian patients. Is it even 8% in pancreas or is it even lower?
It's actually 10% actionability when I did the study 4 years ago. I'm sure it is higher. Uh, range it. I'm sure it will be higher now. But in pancreas, it's extremely low. In most patients, I am doing NGS of late, at least the 50 approximately odd genes. I definitely do MMR if possible, although the yield, as Dr. Ashish mentioned, is extremely low.
Yeah. Okay, perfect. Next slide. So
But
the
that is also because earlier we wouldn't call a P53 or a RAS mutation as actionable, but now that itself has changed. So now soon you're going to have 100% actionability.
Okay, we'll come to that number again. Yeah, so because that is something which we don't know in pancreas, what are the numbers? Next slide. What is the percentage of the RAS mutations that we are seeing? I think that is the most important. Next slide, please. Yeah. What percentage of these patients have the RAS mutation and how are these RAS mutations distributed? So, Dr. Smita, what percentage would have RAS mutations in your practice? I mean, I agree you have tested less, but what general percentage would you expect?
It may vary anywhere between 60 to 80% in different populations for the different RAS mutations which are there in the pancreatic cancer.
Okay. Dr. Ashish?
Yeah, so I think the main challenge in our practice is that in our country, the periampullaries are much more common than pancreatic. So a lot of us actually do not pick up RAS, but actually if you see just the pathogenesis of pancreatic cancer, they say that it is present even in that when the cancer is just intraepithelial. And so much so that some of these molecular biologists say that if you do not find a RAS mutation, you should suspect that if it is some of the other types like acinic cell or one of those cancers. And also the older series have reported lesser because the technology was not sensitive enough. But I mean, in general, it is more than 90% should have RAS mutation. Now, amongst RAS, there are many. We know that G12C and all is not very common, but maybe G12D or other ones are common. There are so many of them I can't remember.
Yeah, very good. So I think you have very nicely summarized. Dr. Aju, your thoughts on this?
So I'll be very honest and admit that I never paid attention to what sort of RAS mutation I'm looking at, because I never even imagined it will be druggable. So I'm looking to learn from you what the different
Next slide.
options.
Next slide. Next slide. So this is, yeah. Go ahead. Somebody was saying something. Okay, I think that's just a disturbance. So the distribution in US, when you look at around 200,000, the commonest is a G12X. X could be G12C, G12D, G12R, and the others are something called G13X and a Q61X. So basically 3 exons, G12, G13 and Q61. These are the 3 exons that are there. Now in the pancreas, as Ashish said, it's around 80% is what the Western data is. So next slide. Now, interestingly, in India, this is not there so much. This is, of course, the data from the West. Next slide. When we actually did an analysis and hopefully it'll get published soon if I do my bit of. So we and Anant Ramaswamy from TMH have done this analysis. So out of 175 patients, this was all done by NGS. Now, there were smaller panels, bigger panels, everything included. Out of 175 patients, the RAS frequency is 68%. 120 had a RAS mutant. So in other words, 32 did not have RAS, which came as a surprise to me. I thought India would be 80 at least. It came only 68. In which the G12D is only 47%. And others, which are the G12C, G12R, G12V, and all are other numbers, which are all small numbers. The non-RAS is also a small, significant amount. So this final paper will be out hopefully sometime in the next few months, but this is some unpublished data that our RAS frequency is around 68%. So this is what our numbers are. Next slide. So this was the Resolute study, very simple Daxib versus chemotherapy. Now remember, this is a second line study. So first line, some chemotherapy they would have got, which could be either 5-FU based or gemcitabine based. In the second line, you would give Gemnapacli or FOLFIRINOX, all Naliri-Fox, Naliri 5-FU, or you could give FOLFOX. Okay, so straightforward study that way with PFS OS. and only exclusions would be just prior therapy or else a CNS metastatic disease. So Ashish, straightforward study. How many patients in second line would be able to take, FOLFIRINOX or Gem-Nab-Pacli and Naliri, 5FU or FOLFOX in real life practice?
Yeah, so usually the performance status deteriorates very rapidly, but it was nice. At least the investigators or the company was confident that come what may, we'll probably beat the chemotherapy, and they did allow. So basically, I mean, I think they just covered for if the Gemna Pacli would have been first line, so second line FOLFIRINOX they allowed, and vice versa. Yeah.
So, Dr. Smita, in real life, how many actually get up with a doublet in the second line? How many patients in pancreatic cancer go to a doublet in the second line in practice?
In general, second line itself would be less than 50%. Doublet would be, I think, less than 20-30% would go for a doublet. Most commonly, we would use Capox or Folfox in that setting.
Okay. Or a single agent, I am noting, and that is
Yes.
something we have done. In fact,
Yes.
Nalgene single agent also used. Aju, your practice, percentage of patients going into
Very,
second line?
very few, in probably low double-digit number, or maybe even single-digit number.
It's a bad disease. We have to accept that. Next slide. So that is the one
Again, and
interesting.
plus the problem, I am also a little nihilistic also in my mindset, when it comes to second line pancreas. So that is also the problem. But now,
Next slide. Next slide,
it's
please.
like people are showing good examples from the.
Also in clinical trials, they'll be looking for fit patients. So I'm sure in centers where these trials are running, they would be scanning their first line patients every 6 weeks just to see whether you can put them on these trials. Yeah.
Yeah. So this is the thing. And second line, at least a FOLFIRINOX in second line, I don't think hardly ever use. First line, you would give Gem-Nab-Pacli because they couldn't take FOLFIRINOX. And then going on to a FOLFIRINOX in the second line is kind of difficult. It's not going to be that simple for many of us. Next slide. So this was the paper. Now, in this paper, actually, when you go into it, the overall population, they're dividing into the G12 versus overall. In the G12, they had 228. So almost everybody had a G12 mutation, in which 86% actually had G12D or a V, mostly G12D. The other RAS were only seen in 13%. And this small subgroup, if you see, RAS G13, Q61 or no RAS, was only 8% of the population. So in other words, the patients who were not having any RAS were there in around 5 to 6% patients in each arm, not even percentage. Now, why this is important is because the Daxib is supposed to work on both the RAS wild type and the RAS mutation positive. But the trial is essentially a RAS G12 trial. Next slide. So, Ashish, would you agree that essentially this trial at least has mostly included only the G12 patients and some other G12 mutations? The non-G12 mutations are actually very little. So, next slide.
Yeah, but this could also mean that this is the prevalence of what you find in your NGS. If it's a true pancreatic cancer and not a mixture of, say, periampullary and stuff
In
like that.
our
Yeah.
results, actually, the non-KRAS is higher. Why I'm is you have,
But they did not want to exclude the other ones. No, this is what they found possibly.
So would it matter when non-KRAS G12D or a non-KRAS G12 group is only 8% in this study?
Yeah. So of course, yeah. So even in this, like, is G12D going to behave the same as G12V? I don't know.
Yeah. The numbers mostly were G12D. So Dr. Smita, again, next slide, please. So Dr. Smita, same question to you. This study is essentially a KRAS G12 trial. If you look at it, it's almost 91% KRAS G12.
Right. And in one of the subgroup analysis, they have not shown benefit in the other in non-G12 KRAS.
Yeah, but the numbers are so less. So, Dr. Aju, if you are designing such a trial, statistically, when you have only 8% of this three different groups, I mean, there's no way you can analyze it. But would you extrapolate the results to this, or would you say, I'll wait?
I don't know, tough questions, Vamshi. Why do you always have to come with tough questions? But again, everybody's hunting, right? Hunting for signals.
Yeah.
These are early phase trials, trying to look for signals and activity in different patients. Yeah.
So the reason I asked is because, somebody would read and say, okay, it's approved for everything. And we are approving something on the basis of hypothesis, saying that it works everywhere. But evidence-wise, I mean, they could have kind of capped it or said only X percentage should be KRAS G12, other percentage should be else. It would have made things a bit easy for us to understand at least. I'm not sure whether we can extrapolate this and say it to be used in every RAS. This is one of, at least for me, a major challenge with this study. Aju, your thought on that? Would you say that a RAS on inhibitor, so mechanistically it works, let it be given everywhere? Or would you say, no, I will stick to this subgroup?
I think for now, when I see the data, it will be important. But mostly I'll stick to the subgroup. Yeah.
You'll stick to the specific side. Okay, perfect. Next slide. Next slide. So the statistics, as usual, slightly complicated, H1, 2, 3, then it goes up, down, arrows. I mean, I have become kind of used to this whole alpha, this thing, that thing. A complicated study, but essentially looking at first the RAS G12. If that is met, then you go to the overall population PFS, then you go to the OS in the only RAS G12 group, then you go to the overall population, then you look at all these other things which are also important. So next slide. So this was the PFS. Remember, this is second line, and at least the results are quite remarkable for pancreatic cancer. You're having a 7.5-month PFS, 3.5 months with chemo. So Aju said in second line, giving chemo is nihilism because it doesn't seamlessly work, and 3.5 months with chemo. For a fit group of patients who are fit enough to get a triplet drug, 3.5 months is what you're achieving. But look at Daxib, 7.5 months. So, that is impressive. Aju, your thought. Impressive. 7 months is impressive with an oral drug.
This is actually truly remarkable. Unbelievably remarkable. So I would rate it as one of the top advancements in modern medicine.
I agree with you. Look at the curve separation. They separate here at 1 month and then they go on separating. Ashish, your thought on this numbers. 0.45 hazard ratio for a second line pancreatic when you're comparing with a strong chemo, which many of us can't give. I mean, this is good results.
Yeah, and I think this is the first time we are seeing responses in this disease, that too in later stage. And I mean, we are not curing people. I mean, but I hope that if you see a result like this, I think straight away the companies would have started their first line or even neoadjuvant trials immediately.
Okay, fine. Okay, the first line is going on, Resolute 303. Dr.
Yeah.
Smith, your thought. 0.45 hazard ratio, doubling of PFS in a disease like this.
Right, agree with everyone else. Excellent hazard ratio. And as Dr. Ashish is saying, it will move to the first line. I mean, as it's already ongoing in the first line.
Fantastic.
And the chemotherapy arm also has an impressive result here.
Oh, 2.5 months
It
is
is a
impressive.
trial setting. We have to see, I mean, in the real world, how does this fare? And in our population, as you are saying, the subgroup of that KRAS mutation itself is lower.
So again, I think very nihilistic of everybody with where Dr. Smita says 3.5 months is better than what she expected for a second line. So that tells you what bad disease pancreas is. Next slide. So this is the overall population. Again, very impressive. But again, like I said, numbers are not much, so we don't know. Next slide. When you look at the overall survival in the RAS G12, again, look at that hazard ratio of 0.40 and an overall survival of 13 months. More than a year survival in a second line pancreas. Ashish, second line pancreas 1 year plus. I mean, what more do you want?
Yeah, so I think it's just telling us that the responses may be durable, and I'm not sure. I think I did not read the paper in detail, but did they allow the tablet beyond progression? I'm sure they would have allowed in some patients. So that also helps. So this looks like a TKI in lung cancer kind of a curve to me, right?
Agree.
Yeah, so which we never saw. We'll see it in biliary tract, but yeah.
Yeah, pancreas. This is pancreas. Biliary tract still. Pancreas. I mean, cholangios, you would expect to see decent results, but a pancreas, Dr. Aju, 1 year plus, happy.
Absolutely remarkable. So the challenge with me when this data came was to explain to some of the well-educated patients who've come, understanding all this data and then telling them, okay, there is a drug available, but I can't get this for your father. That sort of difficult discussion started then.
Yes, that is the most irritating part about this drug. Everybody knows about it, but nobody is able to get it. It's not even approved in the US that they can import it at whatever astronomical price they want. They are not
So,
able to
so
import it.
they just started compassionate access in the
Correct.
US. Yeah.
So the compassionate access, apparently rules are very strict. Somebody was mentioning that they have to be there in the US every
Yeah,
3
in the
years. They have
US.
to
Yeah.
go and
Yeah.
get the drug from the center only. They cannot get it in
No,
any
but
center they
yeah,
want.
but there is a similar drug from Insight, but yeah, I mean that's another company, and but they don't have randomized data yet. But
So
I think just
Insight is
couple of
there.
years we'll have many. Yeah. Yeah.
There is something called tree life or tree something, which is
Yeah.
also doing this. So there are 4, 5 RAS inhibitors. Interestingly, a lot of RAS inhibitors in China. So, those are probably, they have around 5 to 10 in pipeline. So I hope somebody ties up with a Chinese company and brings the RAS inhibitors here. So next slide.
They will take it to the US. No, they'll not bring it here, and then we'll have to pay the US price.
I hope somebody from India ties up with a Chinese company to launch it in India. That is the hope, but you're right. We may do that. We don't know geopolitically what's going to happen. Hopefully something comes to us. Next slide. So again, this was the subset analysis, and Dr. Smita was referring to this. At least in the most of the arms benefited. When you looked at the KRAS grouping, the numbers are so small that I don't even make much out of it. That other KRAS G12 did not benefit, but numbers are too small really to tell us anything. Next slide. Next slide.
No,
So
so Vamshi, I think that
yes,
previous, I think Dr. Smita was mentioning this. I'm
yes,
not sure if the confidence interval is crossing
it's crossing. But
the
you know,
previous slide, the
yes.
forest plot,
We
if
go
you
back
can
one
show.
slide.
Yeah.
Go back. Yeah, look at this.
Yeah. So between okay, they have analyzed D and V together, right?
Correct.
Yeah. I'm not sure if,
Like I
okay.
said, the
Yeah.
other KRAS
No,
G12, other
yeah,
than D.
because there is the same company has another one called Zoldonrasib,
Okay.
which is for G12D, and
Okay.
they have developed another one, maybe, I mean, for some particular reason, right? Otherwise, if this worked very well, why would they have another one?
I'm not
So
sure.
that we'll have to see. Yeah.
Like I said, this has mainly G12, V, and D. So probably that's where they have done it. Next slide. Next slide. Next slide. So RAS wild type, I would say don't have enough data right now. We would probably wait. Next slide. This is the reason probably why it is such a great molecule. Like Aju said, we expect KRAS to be never targeted. What this has done is it actually doesn't directly act on the KRAS. It actually adds to one chaperone called cyclophilin A. The cyclophilin A plus this radaxib goes and attaches to the on state of RAS. So the other RAS inhibitors attack the GTPase activity of the RAS only. This combines to the on activity of RAS, not really depending on the mutation alone. So that tri-complex that it forms is supposed to inhibit RAS all types. That's the logic behind why Daxib works better than the others. Again, it's a molecule which we never thought would work. Next slide. This is also probably why it won the award of, or whatever was voted the award of the best molecule of 2025. Toxicity concerns, I don't think until we know we'll use, but at least the major things that we look at. Events leading to treatment discontinuation is only 1.2%, which is very less. Dose interruptions are there, but dose reductions are only in 36%. So I think fairly looks a decent drug to use. I don't think it'll be a major challenge. Next slide.
But Dr. Vamshi, if you see,
Yeah.
this is one arm there is chemo, other arm it's only a pill.
Correct. Agreed.
So it looks like as toxic as chemotherapy. I mean,
Probably
if you
less is
just
what I
look at,
would say, but you have to use it.
yeah,
I think we have to use it. And again,
unless,
for this kind of numbers, for this kind of hazard ratio, I think we are okay to use the drug, considering the benefit. Next slide. Next slide. Secondary endpoints in this were also important. Pain relief, QOL, next slide, and at least in all of those it showed. Remember, the first trial of pancreas gemcitabine approval was based on quality of life and pain relief, not really on OS. So that was again very impressive results across all the QOLs and everything else. Next slide. More importantly, the question comes, supposing in 6 months it becomes available in the US, what would you use? Next slide. Next slide. So this is just a cartoon which I put to say that at least in the general graph that we talk, clinical and statistical significance, I would rate it very high right on top. Ashish, you agree? At least this molecule?
Yes, of course. Yeah.
Of course. Smita?
Yes,
Absolutely. Okay.
completely, Dr.
Aju? I think in this, we like to be cynical about drugs, but I think this is really deserving of its place up there. I mean, we like to analyze all papers to death, but sometimes you have to accept some drugs are great, are good. At least this is a very good drug for me. Next slide.
I have a query for you, Dr. Vamshi. How do
Yes,
you think whether it should be combined with chemotherapy in the future?
I don't know. I would personally think not really because the data, the way it works, the mechanism of action, if the RAS is mutant,
Hmm.
and the combination of that tricomplex, I think it would be fine to use it as a single agent. That's my take, my feeling. Combining this with chemo will increase your toxicity. Like Ashish pointed out, it is not that there is no toxicity at all. It is if you combine it, the toxicity is going to be more. So that's my take on it.
Yeah.
Ashish,
I'm
would you
not sure
the
not
first line?
sure about this drug. Yeah, not sure about this drug, but similar drugs have been given with, say, gemcitabine or
Correct.
5-FU. I
Correct.
think, Madam Smita, Madam, we just have to find the right dose. I feel because
Right,
in
right.
in this current dose, it may not be possible to combine, but maybe in a reduced dose.
Okay.
Um,
Next slide. Next slide. This is the Resolute 303, which will show. Now, interestingly, in the same AACR this year, the same authors who have done Resolute 302, they had access to this drug and they actually gave it as a monotherapy in first line treatment. This was one study which came in April. Next slide. And they found again a result which was quite interesting. Monotherapy, the safety was very good. And the anti-tumor efficacy, what they had noted was also quite good. Next slide. There were two papers which came out. This was the OS at 6 months was around 83%. PFS at 6 months is 71%. So PFS was 71%, again with 50 patients, not much. But monotherapy does seem to work here. Next slide. The second abstract again was done with chemotherapy. So, Dr. Smita, you wanted to ask about this with chemotherapy. So, there was a study, which is small number. Next slide. Again, they showed that it was not that toxic and they could use it. And in this again, next slide, they showed they showed around 40 patients with a PFS at 6 months of around 84%. So chemo plus Daxib, 84% PFS at 6 months, which is phenomenal for a pancreatic cancer. So this is what, and they have included, ctDNA and all, which let's not discuss that right now. Next slide. So what are the other options that we are giving? What about non-RAS mutant? Are we stuck with chemotherapy only? So Ashish, you spoke about the PRMT inhibitors, the MTAP inhibitors. So that is one more study which is coming up. There's a trial which is going to hopefully start in a few centers across India. Next slide. So the PRMT inhibitors will be one that will work. The same this year's ASCO, there was also a paper about this MEK inhibitor, which is called atebimetinib. So one drug like that. Hopefully we might get it somewhere. Again, showed reasonable responses. 6 month OS of around 88%. So hopefully something new like this will also come up. Next slide. So this is the PRMT or the MTAP inhibitors. And at least for the non-KRAS, I think this would be a good option because non-KRAS, I don't think we should use Daxib. At least in those patients, this would be a good option for our patients. Though the trial, by the way, does not exclude RAS inhibitors. It the RAS mutant patients. So let's see when this study starts. So next slide. So the other trial which I wanted to just discuss for 2 minutes in this was the pemigatinib study, which is a FIGHT 302 study. Next slide. Now this trial checked pemigatinib versus chemotherapy with around 83 to 84. That was the plan. Those are such small numbers. And there was a change in care because the standard of care became chemo plus immuno. So the trial was closed early. Next slide. And in this, when they closed the study early, they showed that there was, practically speaking, hardly any benefit. The hazard ratio was around 0.584, but it was quite large. And the median time was around 8.3 to 6.8. So very minimal benefit. So next slide. So at least in BTC, Dr. Ashish, your take, if you get a FGFR, would you reserve pemigatinib for second line or would you want to push it in the first line also? The fight 202 step. This is 302.
Not sure. I think other than erdafitinib, we don't have anything. No, we
Correct.
don't have any hands-on
Correct.
experience.
Correct.
Plus, these are and these PFSs. These are. Of course, in later line when you have no chemo we use this as a something. We
Yeah,
still yet find the best FGFR inhibitor.
yeah, agreed. So what about the other targets in the BTC? Dr. Aju, IDH1 we have available. Would you use it in first line, or would you reserve it as a maintenance, or would you keep it in second line?
At the moment, I have no experience using IDH mutations in BTCs yet. But these are actually, in my opinion, marginal drugs. We need things like the DAXIPs in that disease too. Otherwise, it's
Yeah.
it doesn't fulfill the promise of precision medicine at all.
Agreed. Agreed. They're actually supposed to be precise, but the precision is not as much as you would like it. Dr. Smita, your thoughts on these targeted agents? Would you use it in the first, second, or would reserve it for the second line?
Not in the first line.
Not in the first line. Okay, perfect. Next slide. So I think that was my last slide. Really, not so much. Next slide. Not so much usage of new molecules. Too many came in this ASCO and ASCO GI, but the one which really was the blockbuster has come around in a big way. So next slide. So again, thank you to all my panelists for being such a wonderful panel. And I thank all the audience who was listening, and I thank the Horizon team. Please do tune in tomorrow for another interesting session and an interesting talk by Dr. Sendil Rajappa on the screening and the use of multi-cancer detection tests. So looking forward to greeting you all tomorrow again. Good night.
Thank you, sir. Good night. Good night. Thank you, everyone, for joining. Thanks to my colleague Daud and Manya. And we'll meet tomorrow. Good night, everyone.